Okay, I'm back, guys. So now that we're done with the skin graft portion, let's start at page 734. So 734, it starts with a Z-plasty scar revision. So these are very popular with plastic surgeons. Basically, that thick scar tissue, if you just cut it out in a straight line, it's going to be very hard to approximate back together. So again, we want that good approximation, right? Eliminate the dead space, close the skin properly so we don't have to come back and revise it again. And of course, every time you cut into a scar, it's going to form more scar tissue. So basically, they found a way around that to close this better. So imagine your scar in front of you in a straight line. Instead of just cutting that out in a straight line, they're going to cut a Z pattern. With this, they can make it to where when they close it, it's not going to pucker on the ends. There's not going to be any little dog ears, they call it, where the skin tightens up together. It's going to be all nice and flat as it should be, because of this Z-plasty scar revision. So basically it's for skin tension. So if there's way too much skin tension when you cut that scar out and it's not going to approximate well, then we're going to do a Z-plasty scar revision. So they can also do this in a W shape, but it's the same idea, Z-plasty revision. So let's go ahead and go to head, neck, and face procedures. So that's on page 736, and it starts with your blepharoplasty. So if you have any of the sagging from the top of your eyelid that covers up your eye, that's typically what we're going to do these blepharoplasties for. But any dragging, drooping around the eyes, they can lift it up this way. So as you're studying, I want you to know the term dermocoliasis. I miss doing the choir thing and making you guys pronounce it to me. So of course, I'd love to see a video of you guys pronouncing these words. If you want some brownie points, you can do that. But make sure you know that term and how this basically starts. So a lot of this happens just from aging, but it's also due to sun exposure. So make sure you know that. It's basically the skin is atrophied, so it is relaxed and laying down over the eye. The only other thing you really need to pay attention to is the fact that this isn't only cosmetic. If it's blocking your vision, that's not cosmetic anymore. It's stopping you from seeing, so it's stopping you from living your life properly. So know that it's not only cosmetic, it does have some real life purposes too. So look at your picture at the bottom of 734. It shows you how they're going to make this incision right here. And typically they're going to have some excess skin that they're taking out when they do this. So you can see why they will do the open blepharoplasty if they need to remove some skin. So look at your endoscopic version of the brow lift. So 738. So this is more brows up, but it can basically be for the same reason. So if your eyelid is drooping and they want to lift from here, they can do it that way, or just to lift your eyebrows up. So they can do this endoscopically now. Yes, they can do it with an open incision too, but typically endoscopic, you can hide those incisions in the hairline. You'll see in your book on page 739, they made the incision right about here. I haven't actually seen that before. We always hid it in the hairline because it's a plastic surgery. If at any point they can hide the incision, they absolutely will. Of course, that increases your risk of infection, and you need to prep the patient properly to do it that way, but it can be done. So it's always going to be through a transverse incision. They are going to use an endoscope, but there's a lot of different ways that they can move the muscle around to where you can actually get that brow lift. So look at page 740 and number 4. So it tells you how the forehead is going to be dissected free from the skull, first of all, so they can move that tissue up, and then what muscle they're going to come across. So know what your corrugator muscle is and know what they might do with that. There's lots of different options. So they could separate it, they could avulse it, they could resect it. The other thing you need to pay attention to are some of your options. So on your procedural consideration number 5, it tells you that they could use a carbon dioxide laser to do this one too. So basically, surgeon preference, lots of different ways to get rid of that muscle and ablate it or resect a portion of it so that you can lift those eyebrows the way you'd like them. Okay, 741, your malar implants. So don't forget, I went over this last week, your zygomatic bones, your zygomas are also considered your malar bones, singular. So a submalar augmentation, that's the proper term for what we're actually doing instead of malar implants. So it's not just for cosmetic reasons. Let's look one more time at that. So performed in patients who have deficient bone structure, atrophy of soft tissue. Sometimes that's from a trauma. It could also be from cancer that has progressed into the bone. So like we talked about last week with cancer in the mandible, it can progress because all of this bone is connected, right? So it can progress and become worse and become part of that zygomatic bone. So we can replace those with implants. Of course, they definitely do this for cosmetic reasons also. I've got some pictures on the PowerPoint so you can see the before and after. No cheekbones, cheekbones. It's very nice to see the difference and all the different types of implants. So take a look at that one and know your bone anatomy for these procedures. Let's look at mentoplasty. So on 743, mentoplasty. So we're talking about the chin. So for these cases, if it's cosmetic, it's basically they don't have the prominent chin that they want and they want that prominent chin. So we're going to do a mentoplasty for them. So let's see, let's look your surgical anatomy and pathology. In the center portion, it tells you it can be for purely cosmetic regions and it's correcting micronaglia. So one more time with the choir thing, I don't get to make you guys say macronaglia, but if you'd like to send me a video of you saying that word to me, I would surely enjoy it. But that's why they're doing this procedure. Typically, they're going to be doing a lot of measuring, so definitely have your ruler out. They're going to measure the difference between your nose and your chin because they want to map it out perfectly because they're plastic surgeons. They want it to look perfect. Okay, so your next one, 744, otoplasty. So these are your ears being pinned back. So if you've seen ears that stick out really far and they want them pinned back, that's an otoplasty. So know your anatomy. Remember that your pinea is the external ear. Remember all of your anatomy that I'm not going to go through every bit of with you because I already gave you an integumentary system review. But make sure you review all the things that you should have already learned in your anatomy. If you look at 747, it shows a really good picture of how they're actually going to do this. So basically, they're going to make an incision behind the ear. You know, I've talked about that. That's one of the dirtiest places. So the nurse has to make sure to really scrub that area well. I have seen nurses scrub it with a scrub brush that we scrub our hands with, clean that off, and then prep the patient because that's how dirty it can get behind the patient's ear. So because it's behind the ear, you got to prep it well. You'll also be doing the holding the ear back thing, or you can use some of the tricks that I already gave you in ENT surgery, so you don't have to hold back that ear as you're passing instruments. You'll see in the picture letter D, you actually might be holding some retractors while they're getting those stitches in before the ear is actually tapped back where they want it. But basically, they're going to undermine some of that tissue to where they can grab more of the fascia that's connected to your face, and they're going to connect that to the ear and get those ears pinned back. So typically, or always a cosmetic procedure. Go to 748. So 748, we're going to do rhinoplasty. We've talked about similar procedures in ENT a lot. This is going to be a little bit different, so I want to point out the differences. So rhinoplasty is reshaping the nose. So notice I didn't say septoplasty like I did in ENT. Septoplasty, we went inside the nose, right? So on this one, notice it says rhinoplasty external technique. I want you to put open next to it. So if you're going inside the nose, it's going to be closed. If you're only going on the outside of the nose, it's going to be open. So open and close versus your external and internal technique, because they could ask you both of those on the CST. So again, rhinoplasty, we're reshaping the nose. They're going to do it a little differently. So they're going to make the incision under the nose, kind of peel it back so that we can see that cartilage and reshape it. So basically this one, we're not making any changes to the internal nasal passageways. So if somebody has a deviated septum, we're not going to go straight for the rhinoplasty. We're going to do the septoplasty. If they have a rhinoplasty on top of that, that's very common, but we're going to separate the two surgeries. Now that I'm pointing that out, look at page 749. So under practical considerations, your second and third bullet point. So this is to remind you that the rhinoplasty can be performed with other procedures. So with other sterile procedures. So anytime you're doing a 100% clean procedure, class 1, you should do that case first. The class 2 procedure, like this rhinoplasty, should be done second. So even though we're not going inside of the nose, it's still considered a class 2 surgery. So you have to make sure to plan out these cases correctly. So if you're doing multiple plastic surgeries, like say you're doing a facelift and a rhinoplasty, you're going to want to do that facelift first and then touch the nose because we want everything to stay sterile. So any dirty area, mouth or the nose, we want to touch that last. On page 750, you'll see where they actually make that incision, that little V at the edge of your nose. And now hopefully you can understand why this is considered an open procedure, not a closed procedure like the septoplasty. Okay, on 751, one of my favorite procedures, rhytidectomy, and that is pronounced right, rhytidectomy. So next to this one, you can go ahead and put full facelift. So I posted 2 pictures for this one. So for some facelifts, I've seen surgeons make a very small incision near the hairline and try to pull the face up from there. Now that can be done, but if you're doing technically a rhytidectomy, a full facelift, that is not the incision. So look at page 752, you'll see the incision. So it starts all the way at the front of the ear and then goes all the way back behind it. That's because they need to get in here and manipulate all of it so they can truly lift the face up and then of course hide those suture lines by the hair or behind the ear. Because of course plastic surgery, we gotta hide those incisions. So a lot of times during these procedures, you're gonna do a lot of tack sutures. Sometimes they even do anchors where they're anchoring tissue to the bone because we wanna make sure that this stays in place and we don't have to come back for another facelift. All right, look at cleft palate and cleft lip procedures. So I worked with a ENT surgeon that now works in Arkansas, and he loves sharing what he does. He goes to Ecuador every year to do cleft lip and cleft palate procedures, typically for free. Depends on how much money they raise every year. But I reached out to him and he was more than happy for me to share his picture and some of the work that he does in Ecuador. But I want you, as far as you're studying, to know the difference between a cleft lip and a cleft palate repair in both of those terms. As far as the anatomy goes, this one's going to be really involved, so make sure you study the anatomy. So on 753, know all of that anatomy. Know when this fetal development occurs, because this is typically congenital. So it happens in that first trimester of fetal development where this cleft lip or cleft palate defect occurs. It could be unilateral, it could be bilateral. There's many different varieties of it, but they still are going to repair it the same way pretty much every time. So look at your pictures on 754. You'll see a cute baby with an adorable smile and the cleft lip. So it's reminding you again here, cleft lip and palate can happen at the same time. So could be both, could be together. So know your terms, chilioplasty for the lip and palatoplasty for the palate defect. This one is one you'll definitely need to have your ruler and your markers on because they'll be making lots of different plans on how they want to approach this. They don't only use a 15 blade, they're going to use that beaver blade inside of the mouth and the nose sometimes to fix that palate. So make sure you have both of those things available in addition to bipolar. Most of these head and neck procedures, we're going to use bipolar instead of Bovie. Okay, look at page 756. So this one goes into detail of how they're going to do this procedure for the cleft lip. So I want you to start at number 3 all the way to the end of number 5. So this is when you really need to know the procedure. So go all the way through that, make sure you understand the anatomy like the Cupid's bow, and you understand why they're making these flaps to do this cleft palate and cleft lip repair. Now this is very hard to explain without a video, so of course I'm going to post a YouTube video on a cleft lip and a cleft palate repair so that you can easier understand. In general, same type of thing, it's plastic, so we want to cover up that scar. It's not only plastic surgeons who do this repair. As I just said, my friend who does this is an ENT surgeon. So, and I shouldn't even put the N in there because even though he's an ENT surgeon, he was tested just for otolaryngology. So you don't have to have the rhino in there in the otorhinolaryngology. You can choose your specialty out of that. So he chose to do cleft lip and cleft palate repairs as an ENT surgeon. So make sure you add that into that it's not just for plastic surgeons. ENT surgeons do this too because we're working on the mouth, nose, and the throat. Know your different types of repairs. So page 758, know that it could be a V or a Y on the palatoplasty, and know your different options for that. There's a really good picture on page 759 so you can see that defect and then what it's going to look like again when they close. So this is, again, not just cosmetic. These children can't eat or breathe correctly because there's a hole in their palate and a lot of times in their lip also. So this is a huge change for their life. They're being able to breathe better, eat properly because of this repair. So it makes a huge difference in their lives. I did get to see some of these as a script tech, but they're really more common in other countries. So that's why you see a lot of doctors traveling to places like Ecuador to do some of these procedures. Okay, so I will go over your hand procedures and your breast procedures tomorrow. I would definitely look over the anatomy. There's a lot of anatomy to study. So again, if you have any questions, please post them underneath the lecture and I'll be happy to answer your questions. And I will add that that's part of your participation grade on the page. You guys have a good night. I'll see you soon.